Brijesh, who is answering today?
Dr. Solairaj
Okay. And
and Dr. Venkatesh.
Dr. Venkatesh.
Yes.
Yes, sir.
Okay, good. So you start your slides. In 5-7 minutes, we'll start. As soon as Dr. Ganesh has joined.
Not yet, sir.
Good evening, Gite sir, Hiren, Mahendra.
Sir, good evening, sir. Good evening.
I think now we can start.
Good evening, sir.
Good evening.
सर गौरंग शाह सर
हाँ बोल.
सर अगली बार से
गुड इवनिंग सर.
सर
Good
इज इट
evening. बोल
पॉसिबल
बोल.
कि हम लोग एक केस का नाम ना रखें, हम लिख दें कि एसिम्प्टोमेटिक केस या फिर पेन इन लेफ्ट फ्लैंक या केस ऑफ हेमेचूरिया. बिकॉज सर इफ यू राइट राइट इनर मास तो ये लोग
हाँ.
क्या करेंगे, पूरा रियल मास पढ़ के आएंगे. देन दे विल नॉट अप्रोच सिम्टम बेस्ड, दे विल अप्रोच ऑर्गन बेस्ड अप्रोच करेंगे ये लोग. तो सर अगर
नहीं
इस वाले केस में कोई भी फाइंडिंग आती है तो लेट्स हैव अ वेग एब्डोमिनल पेन. दैट्स ऑल. लेट अस डिस्कस विद दैट. Let us see which that direction is good. It goes.
Yeah, we earlier we were doing that only.
Hmm.
Unfortunately, people were saying that we want to know so that we can prepare and come. Otherwise, there are people they don't want to present. Then they are not giving name. That is a problem.
But
So what we
but
have
sir, what I,
decided that
No,
let
yeah,
us finish
sir.
the step by step all the cases, and then after these 12-15 cases are over, then as you are saying, na, that is what we are going to do.
that is also okay, sir. Chalega. Hmm.
Then it is like an exam. And after
Okay,
that,
sir.
we are going to have a mock exam immediately after November once they've passed their DNB. So all of us will be there.
Okay.
In Saifi, we have planned out everything. So as you
ठीक है
are
sir,
saying,
चलेगा.
then last
Fine, sir.
three or four classes, we will keep it like that only. Only pain or hematuria or fever, and then your
Okay.
diagnosis management.
Fine, sir. Fine. Hmm.
Right. Okay. So can we start now?
Yes, sir.
कर सकते सर करेंगे करो
Okay.
A 78-year-old female present with the complaint of mild pain in right flank since 2 months.
That's all.
Yes, sir.
Okay. So 78-year-old female complained mild pain in right flank. What things come in your mind?
Mm. Could be you should ask for the nature of the pain, whether it's delaying pain or
Hmm.
continuous intermittent pain. Is the pain radiating somewhere?
Okay.
Associated symptoms, nausea, fever.
ठीक है. Okay. So go ahead. What you have asked in history. Chalo.
Associated symptoms, whether the patient has nausea, fever, any hematuria history is there or not. Any previous episode of similar pains in the past? Was it treated for any stone in the past? Any previous history of malignancy, renal malignancy, was it treated for any opposites in any nephrectomy done? That's also. In addition, if you see a diabetic who would like to ask for the history of placenta illness. So my main differential diagnosis at this point could be a stone, renal stone, or considering the age, could be a renal mass. It needs a further history.
Okay.
Can it not be obstruction? Can it not be polycystic kidney?
78 years, very less likely to be a polycystic kidney disease. Since it is mild pain,
Polycystic will not come at 78. Patient may not have.
very less likely not a polycystic kidney surviving till 78 years. Not sure.
Okay.
So you can say commonest presentation is in the 4th to 6th decade.
Yes, the fourth decade is the most common.
Why
So-
not it is HUN by any
Sorry,
cause?
sir. Sorry, sir.
Why not is it HUN of any cause? Stone, stricture, anything.
It could be a renal stone also, no, sir. It could be a renal stone or a ureteric stone also. So it shows asymptomatic 2 months back. Pain was dilating in nature, non-colicky, in serious onset, not radiated. Gradually progressing.
Sir is saying
No
you should just
symptomatic.
evaluate all causes of hydronephrosis. It
Okay,
could be
sir.
parapelvic cyst, stone, stricture, anything. Okay.
Okay, sir.
My one question: how much common is polycystic kidney disease and
Hmm.
renal mass?
Sorry, sir. How much?
Common
Uh,
polycystic kidney diseases,
hmm.
even age and renal mass.
Don't know, sir.
Which is more common
Renal mass is more common, sir.
at this age, right? Okay.
In this age, in 78 years.
Okay. So
So it was a
right
dull
flank,
aching.
right flank pain means only renal cause. No other organ is
Okay.
involved in the right flank pain.
Could be a gallbladder stone also.
So it doesn't mean being a urologist, you will only think about the urology organs.
Okay, sir.
Whatever the organ in the site where the pain is, it should always be considered, the cause.
Okay. Okay, sir.
Then you will rule out one by one by the history examination. Okay.
Okay. Okay, sir.
Don't be so focused.
Okay, sir.
So
Okay.
by knowing the history of or complaint of pain, if you place the first diagnosis as a renal mass, then it is not good.
Okay, sir.
Because in this age also there are a number of other causes. So primary diagnosis, first diagnosis cannot be renal mass in this patient.
No. Okay, sir. First was renal stone.
Simple ureteric stone, renal stone रह सकते हैं ना. That is more common than the renal mass.
Yes, sir. Renal stone, aortic stone, then followed by.
So 2-3 diagnoses in descending order you should tell. Most common,
Okay,
this is the possibility. Another most common is this is the possibility. और that you have to justify also. आपको अगर ये रेनल मास है बोल के आप अगर रेनल मास बोल रहे तो कौन एक्सेप्ट करेंगे. राइट फ्लैंक पेन 2 महीने का हिस्ट्री है. व्हाई शी शुड हैव रेनल मास अननेसेसरी. ये स्टेज पे बोल रहा हूँ, आगे का नहीं, ये स्टेज पे.
Okay, sir. So for me,
what sir is saying is that your probable diagnosis is the commonest is a renal or ureteric calculus, but the urolithiasis. Second is at this age, your second diagnosis will be the same renal mass and a late presentation. You can say late presentation of polycystic kidney, cystic disease, or
Sir,
it can be because of
polycystic kidney may not be common, but cystic disease with infection,
cystic disease
hemorrhage,
of the
it
kidney.
it is common.
Yeah, and along with that, there may be a late presentation of obstruction.
Simple renal cyst with history of trauma, simple renal cyst with infection, ये possible है ना, more common than the renal mass.
Okay, sir. Sure.
I can put up one more DD with the bladder outlet obstruction with the one-sided more HUN. Maybe bilateral HUN. One side is giving the symptoms. You should have a very broad thinking while the history and examination. Then you come
तुमने
to
directly अगर renal mass बोल के बोला और if I am examiner, I will definitely come to know कि you know the diagnosis. That's all.
But this patient doesn't have any fever and all, no. So there's less likely venous cyst with maybe ureteric stone or venous stone, but no fever episodes, only dull ache, only mild pain. So there's less chance of infective episodes.
So when there is a distended large cyst, when there is a large renal cyst, the commonest presentation is pain only, and that is dull aching, mild pain ही रहता है.
Okay, so only venous cyst. Okay, sir. Sure. So first you have to calculate venal stone, then you would.
My next question is, what is the most common presentation of renal mass nowadays?
Incidental, sir. Routine checkup.
So this patient is having symptoms. Then why you are keeping renal mass as a how things go in a different direction, right?
Okay,
it is simple rules. In every class we say the same thing. Every class you people do the same mistakes.
It's okay, but ये ध्यान में रखना.
What Dr. Mahendra Pal sir was saying, I had the same case in my exam in CMC.
Okay,
it was a bladder outlet obstruction with one-sided hydronephrosis. It's called pop-off mechanism. One kidney takes the brunt.
Yes, sir.
Okay, go ahead.
So she was asymptomatic 2 months later. Started complaining of mild pain over the right flank region. It was dull aching, non-colicky pain, insidious, non-variating, gradually progressing. No specific aggravating factors. We don't take in analgesics. History of person suggests yes, incidence and onset, no infective episodes as a cause of pain, sir. Would like to know for the history. Is she diabetic? Any comorbid? She
इसमें
has
ट्रॉमा की हिस्ट्री नहीं है ना?
history of trauma also should be there. Any trauma.
Okay.
No history of hematuria. No history of burning situation.
No history of
All
trauma.
history negative, sir. No history.
No history of trauma.
Okay. No history of jaundice, facial roughness, low limb edema, no back pain, no bone pain. Okay, sir.
Fine.
Fine, sir. Nothing helps. All a negative history, sir. Couldn't make out anything from this. So would like to know more about your past form. Sorry, sir.
What do you want to do now? The history already you have a detailed history now.
Would like to know is past comorbidity case history and any past surgical history. No known case of hypertension on medication. Family is non-controversial. Hysterectomy.
See, all
It's
of
a
you should be very, very
non-smoker,
fast.
non-tobacco.
This history, na? Listen, this history should have been finished
Okay, sir.
in first 3 to 4 minutes. You have to mug up. All these points, see, if you go behind and see all the history that we have presented, we have got a same format. And you have to understand this format for the pain, for the hematuria, for fever, and the same thing should come within 2-3 minutes, 4 minutes, your history should be over. And I'm requesting you, all of you, please write it down, mug it up. So in exam, they ask you, this should be a protocol. Okay? Fine. Okay, go finish the history. Brijesh. No, before general examination. Okay, so what are the different any specific history you want to ask? Or you want to go ahead?
No, sir, I got all the major history which I wanted. No extra. All the information has been already provided.
Fine.
Sir.
Okay, so differential diagnosis we have already discussed. Now you want to go and find out what else you want to know.
I would like to do my examination, general examination and for abdomen examination. Sir. Right.
Just tell us the specific things what you want to know, and then we'll just show you whether it is there or not.
Would like to do the abdomen examination. Would like to check the genitalia. Would like to check the lower limb if there's any edemas or not. If any tenderness is there, would like to check the exact point of tenderness.
She's a female in genitalia. What you are expecting?
No, tenderness is a radiating point, sir, somewhere in
Tenderness where?
If it's aortic stone radiating to the upper aortic stone to the loin or towards the genitalia. Radiating type of pain, like to elicit.
Okay.
That was nothing much in examination. There's any pallor.
Okay. Brijesh, just show him all the investigation.
So general examination was normal. Abdominal examination, there was visibly a linear scar below the umbilicus of classical hysterectomy.
Is there any importance of these umbilicals, this lower umbilical scar, scar?
She's underwent a hysterectomy before, sir.
Pardon?
She has underwent a hysterectomy before.
No, but does it have any importance? If I say that I have got a scar on my body.
Okay, sir. Would like to know what was that surgical history? What was the biopsy report?
No, cesarean section was done.
Okay.
See, nowadays we are doing laparoscopy and robotic surgery.
Okay,
So
sir.
whenever we are doing this surgery, there may be adhesions. So whenever
Okay,
you are
sir.
seeing, this is a practical thing. Many times we have come across, and there may be lots of adhesions, and you will have problem, initially to do the
Okay, sir.
surgery. So that is the only
Mm.
importance.
Okay,
Fine.
sir.
Okay. Brijesh, go ahead.
So rest was within normal limits, no any abnormality detected.
So can you tell us what abnormalities you will get in a case of renal mass on examination?
It's large mass. I can get I can get it on palpation, sir. Very small mass. I won't be able to take any find in an abdomen examination, sir.
Hmm.
It's large, 8,
What else?
9 centimeter. I can get bimanual positive. Mass may be palpable, sir. Belotable, sir.
Okay.
Belotability and
What is the
bimanual
meaning of
palpation.
belotable?
Like, make the patient lie in supine position with your left hand on your posterior and right hand on anterior aspect of the right flank region. Push it from posterior, sir.
My question was, what is the meaning of belotability and why is it so?
Mm.
No, we can't hear you.
Don't know, sir.
So belotability means when on palpation, when you palpate any organ from the anterior and posteriorly, you can
Mm.
push from the behind, you can feel it the anteriorly. Okay, that is the
Okay.
mobile. It shows the mobility of the lesion, and belotability shows that that organ or mass is attached with the pedicle, not fixed with to the surrounding structure.
Okay, sir.
Okay, so this is
Okay,
the
sir.
belotability.
Belotable.
These are the common questions. So, which other mass in the abdomen are belotable? ये लोग आप सवाल नोट करके रखिए जिससे कि आप
Adrenal, sir.
इनको जो है, हाँ आप क्योंकि हमें 2 घंटे में चीजें कवर करनी पड़ती हैं, तो जो हम लोग सवाल पूछते हैं, you write down, note the questions and find out the answer in a broader way later.
Okay, sir.
Yeah, mesenteric cyst is one of the other belotable mass in the
Mm.
abdomen.
Okay,
Okay,
sir.
yeah. वो भी आंसर आने लगे, ग्रेविड यूट्रस ये सब. But I don't know how will you palpate anterior posterior from the spine. I don't know. Okay, fine. अभी क्या करना चाहोगे? अभी तो खाली ये हो belotability हुआ. What are the other things you want to notice in the patient with the renal mass on examination?
If there's any parallel zag or not, if there's any edema, bilateral lower limb edema or unilateral edema.
Hmm. Then tell the significance, no? Then tell the significance also. If you want to see the edema, what does it
Edema is a
do for you?
chances that patient might have a renal vein thrombus extending up to the IVC. So,
Okay.
or maybe patient is CKD also, edema.
Okay.
Other one is check for pallor.
Varicocele मिल सकता है?
Yes, the left side means varicocele also look for, sir.
राइट में
IVCFs.
राइट में नहीं मिल सकता अगर थ्रोम्बस ने
Yes, sir. Varicocele is not reduced, not
Yeah.
reduced on light.
only case where the thrombus has been extended proximally and blocked the right gonadal vein. we can also
Okay.
get the varicocele. And about the lower limb edema, you can also get in the huge lymphadenopathy, where the
Okay.
lymphatics of
Compressing.
the lymphatics of
Compressing.
are blocked. Okay.
Okay, sir.
And one person showed tell about the dilated veins around the umbilicus, or in the abdominal, sorry, not umbilicus, in the abdomen. Other, it indicates the complete IVC block, and
Yes.
that the collaterals has been developed. But
Okay, sir.
in a 2-month case, it is not so common to have collaterals have developed in 2 months. Not so common.
Okay, sir.
Okay. Okay. What next now? What will you do? Examination done, history done.
As an
So,
extension of my clinical examination, I
so
would like to do
can you narrow down your diagnosis at this moment?
78-year-old female, hypertensive, with past history of hysterectomy, cholecystectomy, complaints of mild flank pain for last 2 months, just progressive.
So after history examination, is your DD remain same, or you can narrow down this little bit, or it remains same because it is unconclusive examination.
So really could at this point I would say mutic stone, renal cyst, renal mass, sir, for differential diagnosis, sir. A parapelvic cyst also, sir.
Okay. But
So,
again, no non-urological organ. Still, you are not so keen to involve them in the DD.
maybe a gallbladder stone also, sir. Less likely. The last option, sir. First one is a renal stone, ureteric stone, renal cyst, parapelvic cyst, renal mass. Last one we have GB stone, sir.
Colon is not possible. Yeah.
Bowel habits are
There's
normal.
no fever, no diarrhea, no, right? But colic like that. Okay.
No anemia also, sir. Bowel
What
habits is
about
normal, right?
Acha, what about the retroperitoneum? Other than kidney,
Adrenal is, sir.
you cannot get anything, any other than kidney.
Adrenal mass,
Okay. What about pure retroperitoneal mass?
retroperitoneal sarcoma.
Cannot be. Can be your DD, or just again you want to focus only on urological organs?
Can be also, sir. Needs imaging, sir. Can be a adrenal mass.
Exactly. When
Can
things are so vague, अगर hematuria हो जाता है इस history में, then definitely you will not go beyond the urological organs. Okay.
Okay, sir. Okay, sir.
When there are vague symptoms or very non-specific symptoms, you should involve all the possible DDs.
Anatomical, sure, sir.
And again, if you find something in examination, during examination, you can again rule out RP mass, mass hai, palpable hai, knee elbow position kiya, it is not moving, it is RP mass. Either
Okay,
kidney mass fixed to the RP retroperitoneum, or it is RP mass, then again you can narrow down your DD. Okay?
Okay, sir.
Okay. Sir,
So
anything else you want to add, Gite sir or Gaurang Shah sir? Or
if you are suspecting renal mass as one of the differential diagnosis, then 1 or 2 line to rule out the paraneoplastic syndrome, 1 or 2 line to rule out the syndromic presentation, 1 or like Vane's Pal or tuberous sclerosis along with इसका 2 लाइन उसको negative history में आ जाना चाहिए. So that if you are keeping that diagnosis as one of the differential, क्योंकि या फिर retrospectively फिर diagnosis होने के बाद में फिर एग्जामिनर बैक लेके जाएंगे वहां पे आपने पैरानियोप्लास्टिक का पूछ लिया क्या, आपने फिर ट्यूबर फैमिली हिस्ट्री पूछी क्या, तो ये सब चीजें बैक जाने के बजाय फर्स्ट टाइम जब नेगेटिव हिस्ट्री पूछते हो और इफ यू आर प्लेस थिंकिंग कि इट इज रेनल मास, तो रेनल मास के साथ ये भी 2 लाइन पूछ लेना, सो दैट कि एग्जामिनर को लगेगा कि यू आर थिंकिंग रेनल मास इन ब्रॉड वे.
okay.
He's hypertensive also. So one of the paraneoplastic syndrome is positive in her history. Don't know for how long she has hypertensive. It's only for last 2 months.
Who else is answering apart from you?
Dr. Soleraj.
Soleraj, you also please participate, okay?
Yes, sir.
So Soleraj, now this is a history.
Yes, sir.
Examination is over. Now what you want?
Sir, first routine, basic investigation, CBC, KFT, urine routine, urine for
Yeah, just tell us.
an ultrasound KB, ultrasound whole abdomen with PBRU.
Okay. Brijesh, show them.
Urine routine, sir. Ultrasound. So this is
Yeah, Soleraj, read it and just tell us.
these are the images of ultrasound whole abdomen. Liver looks normal. Kidney, there is a hypoechoic endophytic, more endophytic mass in right kidney of around 3 centimeters with increased vascularity. Left kidney looks normal. Bladder looks mildly trabeculated. That's it. I would like to ask for report. Hepatomegaly with grade 1 fatty liver is there. History of cholecystectomy is noted. Kidney, right kidney measures 8 into 4.8 centimeter, 3 into 2.5 centimeter heterogeneous lesion in lower pole, low impedance perilesional with low impedance perilesional vascularity, no renal vein thrombosis, and left kidney measures 9 into 4 centimeters, 9.9 into 4 centimeters. Bladder, urinary bladder wall thickened and trabeculated, no evidence of growth or calculus. Full bladder capacity was 678 and post-wide residual 314 cc. History of hysterectomy noted.
Yeah.
Yes, sir.
Tell us. And there is
Now-
a history of cholecystectomy, correct?
Yes, sir.
Yes, sir.
Fine. Now next what?
So did you read USG finding carefully?
Fullness in bilateral renal pelvis.
Okay, fine. What will you do next?
No. What are the positive findings?
The positive findings, hepatomegaly with heterogeneous lesion in right lower pole kidney with perilesional vascularity
And
bladder wall thickening and significant post-wide residual urine.
so that is also very important, na?
Suggest for bladder.
And she has
That
got
is why-
hysterectomy and she has got cholecystectomy.
Yes, sir.
Okay?
Yes, sir.
You should not miss any significant finding on the sonography. Again, you should not focus on only mass. This
Yes,
patient has a very large significant post-wide residual that you should not be missed during the management.
Okay.
Yes.
Okay. Yeah. So what next and why?
I'd like to ask for the contrast enhanced CT scan of abdomen and pelvis.
Okay. Can you add one word in the CT scan that becomes nowadays a standard of care and that gives a very good picture of renal mass?
Triple phase CT.
Yes, right. Whenever you sonography, you have a renal mass, always ask for the triphasic CT scan.
Yes, sir.
And you should know about the what phases in triphasic and at what time of it they all occur. And that means at what interval these sequence should be taken. Okay.
Yes, sir.
Nephrogram, arterial, cortical phase, venous phase, and excretory phase. Okay.
Yes, sir.
Okay. So, chalo, before going to CT scan, what things now you know this is renal mass with significant post-void residual. So, what things you would like to know on the CT scan?
The size of the mass, renal
So
stoichiometric
I will
score.
just, I will just make your life easy. So any malignancy का description जो होता है that is always based on TNM staging. Okay.
Yes, sir.
So whenever you see CT scan or MRI or PET scan, try to describe as per the T stage of that organ, followed by N stage that organ, followed by M stage of that organ.
Yes, sir.
Right? And if there are bilateral organ, always mention about the other side, whether it is normal or abnormal. Okay?
Yes, sir.
So now, keeping the T stage of renal mass and TNM is a renal mass, what specific things you would like to see on the CT scan?
Right to know the size of the mass,
Okay.
location
That
of the
is
mass,
T1, that is T1A and B. Okay.
Yep.
Right.
Location of the location of the mass, then whether it is extending into the renal vein, segmental vein is involved, or into the sinus fat is involved or not.
Whether it is exophytic or endophytic.
Fine.
And whether extension of a tumor.
But in TNM staging, it is not mentioned about endophytic or exophytic.
Only in case of if you're going for you're going ahead with whether tumors extends beyond the aorta, so into the ipsilateral adrenal, and it's a lower pole tumor, that's like extension of tumor to the
my question
aorta.
was different. My question was, when in TNM staging, upper pole, lower pole, endophytic, exophytic is not included, then why do you want to see these features on CT scan?
Since it's a small tumor, if you're planning for a partial nephrectomy, your renal nephrometry score, Paduga score comes into play. So know the complexity of the tumor. You want to know whether it is exophytic or endophytic, or it is cross the interpolar line, or it is.
Yes, it will help you in approach and patient counseling. Okay, if you're planning for NSS. Okay, good. Okay, fine. Rest.
And next, after describing the T stage, then you like there's any enlarged on the right side. So there is enlarged right paracaval nodes, or pericaval nodes, interiotocaval nodes are not.
Neither. T staging में you missed very important thing. T3 disease, T3A, B, C. Other than
told no, sir. Told no, T3A involves the periculture system, renal sinus, perirenal fat, or segmental renal vein, or the IVC below the level of
thrombus. You should not say tumor thrombus, right?
Tumor thrombus. Okay.
Tumor thrombus. Okay. Okay. And something is more in T stage is the adrenal.
Yes, sir. Yes, sir.
Adrenal is the only organ that can define the stage as a T stage or M also. You know or not?
Yes, sir.
Okay.
It is a lower pole mass with ipsilateral adrenal involvement is T4, and if it is contralateral adrenal involvement is M stage, M1.
Okay, so lower pole mass with involvement of adrenal, again M1. If it is a continuous involvement, it is T4. Okay?
Yes, sir.
Yeah, fine. Sure. ठीक है, T हो गया, N हो गया. Then
liver, sir, solid organs, bone.
So it is it is M1, na? Lung, liver, bone, etc., etc. So that is okay. Now, can we open the CT scan and somebody can describe it the same way. And again, one thing remaining is the
Bladder.
contralateral kidney.
You have to see the bladder.
One more thing in the CT scan, the collaterals.
Okay, sir.
Sometimes there are huge collaterals. Just you should know on the CT scan. Okay. Anyone can describe the mass in the CT scan? So in the exam, you will get, I think, 5-6 minutes or 10 minutes for the description of CT scan, if it is there.
Okay.
You should be quick and correct.
To start with, the opposite left kidney appears normal on the CT scans. There's no stone, there's no tumor on the left kidney. Coming to the right kidney, hypoechoic 3 centimeter, completely endophytic tumor seen in the junction of mid and lower pole.
Heterogeneously dense, partially exophytic, growth in lower pole, approaching more towards the perirenal sinus fat, with a segmental artery supplying the mass. And the artery, there is single renal artery, single renal vein. So the renal nephrometric score can be around 1 plus 2. We need more films to say nephrometric score, sir, as such.
So tell me the components of nephrometry score.
First, it's a radius, diameter of the mass. Less than 4 is 1, 4 to 7 is 2, more than 7 is 3.
Exophytic or endophytic?
Exophytic, more than 50% exophytic is 1. Less than 50% exophytic is 2, and totally endophytic is 3. Nearness to the pelvic, nearness to the renal sinus, less than 4 mm, more than 7 mm, it is 1, 4 to 7, 2, less than 4, 3. Anterior posterior, which is designated as ARP, L is pole, whether it is a polar line towards the away from the polar line, or in between polar line, or in the middle of the kidney. Location.
How will you define the pole?
Polar line.
Mid pole, upper pole, and lower pole.
Polar line is one which is drawn from the junction of cortex, involuting cortex to the pelvis, sir.
Okay.
And this interpolar line crosses towards the in the center. If the mass is crossing this interpolar line, it comes under 3. The score is 3.
Score is 2, sir, because interpolar line. 3 is completely.
Hello.
Completely inside.
Yeah, please go ahead. You were saying something. Please go ahead.
No, sir. This one. Interpolar line, if it is completely above the interpolar, it's 1. If it's partially crossing, means 2. If it's completely between, it's renal score is 3.
Okay. So you must know the different types of nephrometry score and their values and their importance.
Yes.
Okay. Yeah. So there is also one thing is there in the left lower picture, some bright thing. Is it stone? Or it is calyx?
Plain
Not
image,
able to make put in.
plain images we have to see, sir.
Okay. Okay. So why these nephrometric score were proposed?
To know the complexity of the lesion. So whether partial nephrectomy is feasible or not, to counsel the patient chance of conversion to partial to radical, to be prepared for the complexity, to know whether in invasive procedures like laparoscopy, robotic or open, to be prepared for the ourselves, for surgeons, and for counseling the patient, for informed consent also.
Okay. Okay, fine. Now what next?
Next, since apart
Achha,
from
as
the
this is the what are you saying?
We would like to see the report.
Okay. Yeah. मेरी रिपोर्ट बता दीजिए. Can someone read?
Yeah.
Important points?
ill-defined hypotenuse, enhanced mass, 3 or 3.5 centimeter, with no extension outside Jagata assessing, no involvement of PCS, right renal vein is normal. Mass is supplied by a single artery and single veins.
Okay. So again, in the CT scan reading, we miss one thing about the arterial
Urinary
venous
bladder road is
supply of the kidney. Okay. Okay, fine. So what are the features of renal mass on CT scan?
Heterogeneously enhancing, sir.
Okay, वो तो रिपोर्ट में लिखा हुआ है. But what is the specific sign? कुछ CT scan में कुछ होता है ना? Hounsfield unit क्या होता है?
40 to 40 to 70.
40 to 70 what?
Hounsfield unit per mass.
No, sir is asking why it early enhances. What happens actually? Explain the pathology.
can differentiate clear cell papular cell based on Hounsfield unit, I guess. Not sure, sir.
मतलब
No, he's
बताना
asking you
कि-
why there is early enhancement and early washout. This is a sign of malignancy, correct?
Yes, sir.
So why it is happening?
Mass is always angiogenic, and there will be more vessels supplying. New angiogenesis is there in any malignancy. So newly developed capillaries will be supplying the mass, and it will be attracting more blood supply, sir. So it is yearly enhancing, and then washout is also high because of good perfusion and
Oh, because of the
drainage.
AV malformation. No?
Yes, sir, AV malformation.
So it is draining away very fast,
Yes, sir.
not the normal system. That is number one. Number two, I want to ask you, in which conditions you like to do MRI?
If patient is having any
CKD. Or
Okay,
patients having
one
a
is
renal.
Pardon?
The patient is having a CKD where you can't use a contrast.
Number one. Number two?
Ultrasound shows there's a tumor thrombus where you want to differentiate tumor thrombus and bland thrombus, whether IVC is involved, infiltrated or not.
Okay. Second, third?
Contrast anaphylaxis, sir. History of contrast anaphylaxis.
3, 4? Suppose this female is 35 years old, 45 years old, yeah, 50, between these. And if she's a pregnant, then if she's less than 45 and pregnant, now what will do?
Now also
You can do MRI, correct?
Also,
yes,
to define
Okay.
the level of the thrombus. If there's IVC thrombus, you want the exact level of it, right? Infrahepatic, suprahepatic.
Yes, sir.
Fine. Is there any role of PET scan? Thyroid?
No role, sir. No role for PET scan and renal mass
Why?
at this point.
Why?
Because the PETs, FDG PET gets excreted in the urine, so difficult to differentiate the lesions.
Sorry, what did you say?
The fluorodeoxyglucose gets excreted in the urine also.
Okay.
So difficult to differentiate the lesions.
Any other reason? The uptake is very low, na, in the mass. It is not so classical uptake
Not
in like
FDG,
FDG PET scan.
not so.
It
Ability is less.
usually it becomes equivocal, but however, for a metastatic site, FDG PET it can be done. But for the primary staging, FDG PET का role primary staging के लिए नहीं होता है.
You should have said that actually, rather than making a very bold statement that there is no role in renal mass. You should have said in primary renal masses there is no role.
Okay, sir.
Okay, so
Metastatic, sorry.
malignancy के cases के लिए हर चीज का एक रीजन होता है. Even everything has a reason, but you should not have just a blanket statement कि एक बार बोल दिया सब फिट हो गया. You should read, and when you read, you will come to know. Okay.
Okay.
Okay, now what is the role of DTPA? Will you ask for a DTPA renal scan?
No, sir, I didn't.
Okay, would you like to ask for it? Would you like to ask why sir is asking about DTP?
No, I would not want a DTPA for this patient.
Okay.
Cortex is good.
In which condition you would like to do, if not in this case?
Patient has thinned out cortex. I would like to know the differential function of the right kidney, whether preserving the right kidney is useful or not. Patient has thinned out cortex, in which case I'll ask for DTPA scan.
So do you know it is defined as a absolute and relative contraindication? Sorry, relative indications. Do you know or not?
Don't ask.
Okay, so जो absolute indications होते हैं वो होते हैं mass in the single kidney और mass in bilateral kidneys. Okay. वहां पे आपको DTPA करना ही करना है. ठीक है.
Okay.
Relative indications होते हैं past history of any surgery in the kidney. Okay. Patient having long standing diabetes or hypertension or any other condition which may affect or is affecting the kidney function.
You may have two pathologies, one stone on the opposite side. Then you have to do it.
ठीक है. जब ऐसे और otherwise in healthy patient with on CT scan other kidney is good, it is not recommended.
Okay.
अभी ये नहीं है कि अगर क्रिएटिनिन 1.8 है और इमेजिंग में सब कुछ ठीक है आप नहीं करोगे, क्योंकि ऑलरेडी इसको कंपोनेंट है सीकेडी का, तो आपको करना ही करना है इसमें, है ना.
See, suppose if you want to find out that if you go for a nephrectomy, what are the chances that patient will develop CKD? Suppose if patient doesn't have CKD, then you want to find out what are the chances that this patient will develop CKD and prognosis. So you can tell the patient in advance that
based on DTPS.
What are going to be the consequences. So that is also one of the indication. Okay. And then second most important thing is you want to save. For example, if the opposite kidney is not working well and then you will try your level best to save the other kidney where there is a tumor and you would like to do nephron saving surgery.
So I would say in today's class, you have to learn one thing. Don't make rigid, fixed statements. You have to think and then answer when examiner asks you.
So in this case, there is no indication because the creatinine is also less. The GFR is quite high, correct? And
Yes, sir.
patient is also old.
Mm.
Opposite kidney is working well. So you may not ask for DTPA renal scan.
Okay, sir.
But by chance, if you say DTPA renal scan and then examiner asks you why you want to do DTPA renal scan, you can always say, okay, sir, in this case, I might end up doing radical nephrectomy. Patient is old, GFR is compromised. I just want to find out whether there are chances of this patient going into CKD.
CKD.
And I can explain the condition to the patient that what will happen after the surgery.
Sure, sir.
Okay, so now what you want to do? Do you want to do any genetic examination? Are there any
No.
syndrome you know of? Yeah.
Von
Should I
Hippel
run?
syndrome, good.
No, step
Von
one by
Hippel
one. Tell me
syndrome.
what. Yeah, one Hippel.
BHL syndrome.
Okay, what is the test?
And clear cell carcinoma.
Yeah, what are the things you get in
So
that?
also what is hemangioblastoma of retina, hemangioblastoma of cerebellum, don't know exactly, sir. And adrenal pheochromocytoma, polycystic kidney disease.
What about bilateral multiple renal masses?
That is the main thing.
Okay, sir. Okay, sir.
And lower down? Anything in the gonad? Which other syndrome? Swastik, can you unmute yourself and can tell all the syndrome? Swastik.
Yes, sir. Hello. Good evening, sir.
Yeah, tell all the syndrome what are contained.
Sir,
And
first is BHL syndrome, sir. Chromosome number 3p25, sir. First BHL में सर अपने को मिलेगा ये retinal hemangioblastic mass, cerebrospinal hemangioblastomas, then sir pancreatic cyst of neuroendocrine tumors of pancreas, renal mass or renal cyst, then sir pheochromocytoma and epididymal cyst or broad ligament cyst, sir, in BHL syndrome, sir. Then sir hereditary papillary carcinoma syndrome, sir, HPLC syndrome, and then इसमें papillary carcinoma of renal papillary carcinoma मिलेंगे, sir. Then sir HLRCC is there, hereditary leiomyomatosis and HLRCC, yes sir, renal carcinoma syndrome. HLRCC में sir अपने को renal RCC, then sir uterine leiomyosarcomas, uterine and other leiomyomas मिलेंगे सर अपने को. Then sir there is P10 syndrome or Cowden syndrome is there, sir. And
okay.
Yes, sir. And sir there is Barth-Houdt-Dubé syndrome, follicular gene, sir. इसमें सर अपने को renal cell carcinoma, lung cyst, spontaneous pneumothorax मिलेगा, sir. And then another syndrome is there, sir. SDHB syndrome, SDHB-A, SDHB-B syndrome, genes are involved. इसमें sir renal cell carcinoma, mostly papillary type or clear cell type. Then sir इसमें थायराइड ये पेपिलरी कार्सिनोमा ऑफ थायराइड मिलेगा। हाँ यस सर। एक और कुछ
So man 1 and man 2 is not involved in this.
नो सर, इसमें नहीं है सर, वो दैट इज इन एड्रिनल मास सर। सो
Okay.
7 सिंड्रोम्स का नाम सर इसमें रहता है, VHL सिंड्रोम, देन HLRCC, HPRC, देन ये कॉर्डन सिंड्रोम, बर्थ-हार्ट सिंड्रोम, SDHA, SDHP सर, ये रहेंगे सर 6 सिंड्रोम्स।
Okay. Fine. This question I have asked only so that whenever you listen, again and again, this goes into your mind and you remember the syndrome. Because at the last moment in the exam time, whether you are appearing for theory or practical, you will not be able to remember unless and until you heard it many times. Fine. Okay. So Solairaj, now what you want to do? Solairaj?
Sir, am I audible, sir?
Yeah, you're audible. Tell me.
Sir,
No, there are, what you want to do? You want to do the watchful waiting? You want to keep an active surveillance? You want to do partial nephrectomy? You want to do radical nephrectomy?
Would like to counsel this patient for
Okay.
partial nephrectomy.
With?
Sir.
No,
Will tell
you counsel the patient
right.
with, they always say in exam, with empathy and sympathy. Okay? Even though the
Okay, sir.
meaning is almost same, you have to tell that with empathy and sympathy, I will explain the situation to the patient because it is a malignancy, right?
Okay, sir.
It is not
Okay,
any stone disease that you can just tell them,
Yes.
okay, I'll remove it and you will be fine. When you sit
Okay, sir.
and tell someone that you have got a cancer, even if it is a very early stage or whatever it is, for that moment, he will feel that the line below his leg is just slipping away.
Yes, sir.
Okay? And he feels that the whole sky is falling on them.
Yes,
So
sir.
please, you have to say that, sir, it's a cancer. I will like to talk to the patient with empathy and sympathy. I like to explain them everything and about
Okay,
the management.
Sure.
Fine. So what you want to do?
Partial nephrectomy.
Hmm?
And I would like to do a base uroflowmetry also, because even in CT scan a bladder was distended with cavitations. So I would like to have a uroflowmetry also. This patient.
Okay. Yeah. So uroflowmetry is obstructed. I'll tell you very frankly, we have done urodynamic study also, and she has got actually, this is not given in the history, but she has got a neurogenic bladder. We have advised her to do CIC. So forget about that part. We don't want to include into this.
Okay.
She is doing CIC and she is Sadhvi. So her, supporters, her subordinates, they are doing it for her.
For this, okay. I would, with empathy, sympathy, I would like to counsel for right side partial nephrectomy. So I would like to tell the preoperation expected complications.
Tell me. What are the chances of doing this partial nephrectomy successfully without complication? Is it exophytic? It is totally endophytic.
Oh, sorry, sir. Forgot. It's completely endophytic, sir.
So how will you do it? Can you do it in a natural way, normal way? So even if you want to do partial nephrectomy, what extra tool you will require? What extra tool you will require?
Intraoperative.
So you will require for operative ultrasound, correct?
Yes, sir.
Okay, fine. So now you tell me, is it a easy case or difficult case for the partial nephrectomy?
Difficult, sir.
This difficult case.
And she so
We have to
tell me,
convince her open conversion as well as radical nephrectomy, sir.
okay, so now you tell me the points which favors radical nephrectomy and the points which you think are correct for the partial nephrectomy.
Vessel, the renal vasculature is like only one renal artery is there, so it is possible to control it. So with the open radical, like open partial nephrectomy, we can feel the consistency of the mass and
Why do you want to feel mass consistency? Is it going to change your management or strategy?
Answer, right? We have to go for another two short cases.
It is not required, no? In examination, you should be very careful what are you speaking. Okay?
okay, sir.
Yeah. So now answer what sir has asked.
With the help of ultrasonography, we'll go ahead with partial nephrectomy.
Okay, so you are saying that you want to do a partial nephrectomy if possible, otherwise you will do radical nephrectomy. Correct?
Yes, sir. Yes, sir.
Okay. So in any small tumor, you will always say that I will try to do the nephron saving surgery, but if it is difficult, then I will not take chances. I will definitely call the senior person to help me out. But if it is not possible, we will go for a radical nephrectomy, right?
Right.
And if there are cases which are definite indication for partial nephrectomy, always partial nephrectomy. If there are definite indications for radical nephrectomy, talk about it. Fine. So Mahendra, can you just explain them how to go about?
So one thing also written in guidelines, if any case can be done with open partial nephrectomy, one should not attempt laparoscopic radical nephrectomy. Is it like that you commit the patient, I will do laparoscopic surgery only, and you find it doing difficulty laparoscopically or robotically and a partial nephrectomy, it is always better to open and do the partial nephrectomy rather doing robotic or lap radical nephrectomy. Am I clear?
Yes, sir.
Yeah. So second, again, as sir said, in this case, you have to explain the patient with sympathy and empathy that he is having stage 1 cancer. You should know about the stage 1, 2, 3, 4 in the RCC, the stage 1 cancer. And you have to explain the survival is very good based on, and that these are the approaches, open, laparoscopic or robotic, and kidney can be saved by removing the mass only, though it is a difficult mass, needs intraoperative ultrasound, and rare chances of conversion to radical nephrectomy always there, maybe 1 to 2%. That need to be explained to the relatives. Post-op, and also about the post-operative complication, and its score might be, if I'm not wrong, it may be 8 or 9. So the complications क्या क्या हो सकते हैं इसमें? Anybody can tell?
Hematoma, urinary leak, intraop hemorrhage.
And post-operatively pseudoaneurysm, which may require angioembolization.
Okay.
So because sometimes patient may ask, you did not explain me about the additional procedure, but you never know which patient develops pseudoaneurysm and hematuria, which requires angioembolization. So these all things should be explained before the surgery, and make them assure that by this methods your kidney can be saved and your survival, or maybe the you can live a normal lifestyle after the surgery. And the follow-up will be based on your histopathology report, maybe low risk, high risk, ऐसे करके. A report, what we have done in this case?
Pardon?
So what we have done in this case, the
No.
robotic
We
analysis?
see, robotic. I consulted with the radiologist also. We have seen everything, and it was very near to the hilum, and the
Mhm.
chances of bleeding and all were very high. So we talked to the patient. She is already 75, 76 years old. Opposite kidney is absolutely normal. Second thing is they are service. So if something happens, any complication, they are not
Okay.
staying at one place. They are moving around continuously. Plus lots
Okay.
of
Then radical
other.
will the
So we did
plan.
a radical. Yeah, radical.
Okay.
Do you have
Okay.
specimen, Brijesh?
No, sir. At present, we don't have.
Okay, fine. Photograph you don't have, na?
अच्छा HPR आया क्या?
Pardon?
हिस्टोपैथोलॉजी रिपोर्ट आई क्या?
नहीं,
हिस्टोपैथोलॉजी
pathology
रिपोर्ट.
report नहीं है. नहीं.
Okay. So
We'll put it on the.
what will you do when you have a pathology report in your hand? Now, what will you counsel the patient when you have a pathology report?
We have to stratify this case as a low risk or high risk, and then we'll advise for the follow-up accordingly.
Again, it is a very vague explanation. Examiner only want to listen one word or maybe two words. We would like to stratify the patient as per the Lebovich criteria into low, intermediate, and high risk, and the follow-up protocol will be based on these criteria, which you usually do in your center.
Sir, NCCN.
Okay. So any you do any criteria which have score 1 to 1 or 1 to 3, 4 to 6, 4, 5, and more than 6, right? Something like that. Okay. What about the non-surgical management of small renal mass? Anybody can tell one by one?
First, if the patient is having poor like comorbidities and less survival chances, then we'll advise for watchful waiting. And if patient is having good survival aspect and patient is on regular follow-up, we can ask for active surveillance or minimal invasive procedures like ablative ablations like radio frequency ablation or like radio ablative procedure or cryo ablation or microwave ablation can be offered.
Okay, so you should know also one data about these therapy and it comparison with the partial nephrectomy and the contraindications of ablation therapy, and one to two line about the RT in the RCC. The patient who are not fit for surgery and not willing for surgery, and may not maybe contraindication of ablative therapy, they can also be considered for the RT for the renal mass. But again, not in the extended, it may be the trial or maybe as an exceptional case. Okay.
Yes, sir.
Okay. Sir, we can go to other case. I think we have
Yeah,
covered
you go
almost
to
everything.
Fadafat. Yeah, we have got two good cases, short cases. You can, complete all the discussion about small masses in this.
Okay, so we will just focus on the anything they miss, or we go
Yes.
on the go fast. Yeah.
68-year-old male patient came with complaints of dull aching pain over left flank since 2 months and had a history of hematuria 25 days ago. Patient was asymptomatic before 2 months, after which he started complaining very mild pain over left flank. Pain was dull aching, low grade, non-colicky, insidious onset, non-radiating, gradually progressing, not associated nausea, vomiting, fever, no specific aggravating factor, relieved on taking analgesics.
Okay.
Patient also noticed hematuria, like reddish discoloration of urine 25 days ago, which was insidious in onset, painless and self-limiting. Hematuria was present throughout the passage of urine and was not associated with any physical trauma. No specific aggravating or relieving factors, no clot.
Okay.
Just go ahead.
No history of dysuria, lithuria, no history of pain at the time of hematuria, no history of previous instrumentation or catheterization, no history of nausea, vomiting, no history of jaundice, patient prominence, exertional breathlessness, lower limb edema, no history of backache or bony pain, weight loss, no history of bleeding disorder, anticoagulant therapy, no history of blood transfusion, no history of radiation or chemotherapy.
Rest history was also normal.
All the histories is normal. General examination. Anything specific?
No, sir.
Brijesh?
No, sir.
Nothing. Everything was fine. Okay. Now, yes. Solairaj, what you want to do?
As routinely with CBC KFT, urine routine, ultrasound abdomen as an extension of clinical examination. Hemoglobin, creatinine 1.1.
Patient had hematuria.
Urine, then urine for cytology, malignant cytology.
Okay.
So I have got two questions. That in all the cases of hematuria, you will ask for cytology, number one. And number two, is it necessary to do ultrasonography when there is a gross hematuria and you are 100% going to do CT scan, correct?
Yeah.
Yes,
So, yeah.
Yeah. So tell me how you are going to justify these two things.
Sir, in this age, pain is of a dull aching nature, and it is not colicky. There is no issue of lithuria, so dull aching pain with hematuria, we have to rule out malignancy, sir. So urine for cytology, malignant cytology is needed, and ultrasound as it is extension of clinical examination.
So in malignancy, which are the malignancy where you get a hematuria?
Renal cell carcinoma with infiltrating into pelvic cell system or upper urinary tract urothelial carcinoma, upper ureteric malignancies,
Correct.
bladder malignancies.
So sometimes it happens that the malignancy, okay, may be situated very near to the pelvic cell system, that is renal cell carcinoma, and infiltrating into the pelvic cell system, and that is the time when you are not sure whether it is the upper tract urothelial malignancy which is going out, or whether it is laterally, or whether it is a renal cell carcinoma which is infiltrating and patient has got hematuria. So you like to do this thing, cytology, urine cytology. Fine. Number one. And why you want to do ultrasonography? So your answer should be, yes, sir, once I know the pathology, sometimes suppose if it is because of only stone, I may not do triple face, full abdomen and pelvis and chest CT scan. I will concentrate only on the kidney, ureter and bladder. And you may not do even contrast enhanced. You may do only, you understand? You can do only plain CT. So you can justify saying this. Okay?
Yes, sir.
Okay.
No,
fine.
sir, urine cytology, whenever the person has a suspicion about TCC, or the mass when placed centrally placed mass, these are the only two indications for going for cytology. And sonography, in spite of you do sonography or don't do sonography, whenever there is a renal mass, CT is always indicated, I feel. If I'm wrong, Mahendra, you can add on that. Because if you have suspicion of malignancy in the renal mass, then you better to go ahead with CT scan for to have planning of either partial or radical or enucleation or anything. What is the plan you are there in your mind about by doing the surgery? तो CT तो compulsory है sir. CT
Sir, sir was not debating
नहीं
CT. He was saying CT is necessary, but would you like to do sonography? That was what he was saying. He was saying
सोनोग्राफी देखो सर, सोनोग्राफी अवॉइड करना कि नहीं करना. सोनोग्राफी कैन बी डिफेंडेड. हेलो.
yes sir, we are listening.
हाँ, तो सोनोग्राफी बोलना ही अच्छा है, क्योंकि सोनोग्राफी को डिफेंड कर सकते हैं. सोनोग्राफी में एटलीस्ट ऑर्गन ऑफ ओरिजिन, द
yes, sir.
बेसिक
Yes, sir.
नॉलेज अबाउट द मेटास्टेसिस, साइटिस है, लिवर मेट्स है, सब कुछ चीजें मिलती है. और 5 मिनट का जॉब है, इजीली अवेलेबल है, लो कॉस्ट है. एक्सटेंशन ऑफ क्लिनिकल
Yeah.
एग्जामिनेशन ऐसा करके डिपेंड कर सकते
Correct. So students should say that, sir. They can say that it's our institutional protocol. We do it at bedside. It is easily available, and we are surely
It
going
is
to proceed
easily
for
available, low cost.
Yeah.
Many informations will be achieved, and depending on that, I can plan out for my CT scan. Correct?
Correct. Correct.
हैं. करेक्ट.
So, like,
Fine.
sir, last class we discussed that sometimes if it is a stone, you may not ask for a CT angio. But if you see a
Exactly.
tumor, you may ask for a CT angio. Also, if
Right.
you see small tumor, you may plan for a partial nephrectomy. So you will plan it accordingly, that CT scan. So it may help you plan the
Perfect.
CT also.
Correct. Huh? So all of you are requested to please write down this line, and you in exam just talk like that. And only then the examiner will understand your language. Fine. So now what you want to do? उसको sonography दिखाओ. No growth. Yes. Any one of you? Solarite?
Sir, I'm not able to see the kidney properly, sir. Like liver looks normal, sir, but one kidney left side, right kidney looks normal. Left kidney I'm not able to appreciate properly, sir. In bladder, some echogenic echogenicity is there.
Just
Maybe
see the first upper one. Just see the upper one. You can see the bladder. Correct.
sir,
And
bladder.
then you can see the prostate. Can you see the prostate?
Yes, sir. Yes, sir. In
Okay. Then
with some
you come down.
protrusion. Sir. Below prostate. Sir.
Okay. No problem. Just show the report.
The previous image, maybe we can find something in previous image.
Now see. Can you see?
Sir, sir. There is a heteroechoic mass in left kidney with no post-acoustic shadowing. Maybe
It is rounded cystic lesion. Can you see?
Cystic, sir. Cystic component is also there. Solid is also there.
Yes.
Complex cystic lesion.
Fine. Just show result report.
Liver looks normal. Right kidney appears normal. Left kidney appears mildly enlarged. Lower pole of left kidney shows well-defined round soft tissue mass of around 4.8 into 4.7 with central cystic changes. Color Doppler showed vascularity within soft tissue component. Upper and middle pole looks normal. 4.8 into 4.7 mass. Prostate looks normal. Bladder well distended. Yes, sir. T1B mass.
So now what you want to do?
CT, triphasic CT, sir, with excretory images like bladder. Triphasic CT.
Why do you
By
know?
show,
Would you like to do a biopsy of lesion? Because written in the sonography, FNAC or true cut biopsy can be also be done. So
But this
why not
patient,
biopsy?
we will most likely plan for definitive management, sir. If the patient is having any, like if the patient is not fit for surgery, if patient is moribund, then to give any active surveillance or to give any minimal invasive procedures like radio ablation or cryotherapy, then we will ask for biopsy, sir. Otherwise, we'll wait
So
for.
no, you
first
said
thing you should tell about this patient. So you should say that in this case, sir, I would not like to do it, or you would like to do it, and then you give the other indications that these are the generally the indications for doing.
Okay.
And you said if patient is not fit for surgery, when patient is not fit for surgery, what do you do to use of having active surveillance?
No, watch plating. No, sir. Sorry.
So again, you should use your word very carefully. Okay.
Yes, sir.
So now basically, when any examiner asks whether you will do active surveillance or not, so पहली चीज ये कि sir, I will not do active surveillance renal biopsy in this case, or maybe in case of renal cell, basically this case, and then you
Yes.
can answer later on, sir, as the indications of biopsy of this, and this case is not suitable for the, I will not do the biopsy in this case. You should know the indications of biopsy in the renal mass. Okay.
Yes, sir.
So what are the contraindication of doing biopsy in this case?
There can be tumor seedling or there can be.
Why you don't want to do biopsy in this case?
Sir, definitive management will be surgery, sir. Like partial nephrectomy or.
So
As
what
Arey
that
Baba,
what
are
what
you
that
are you
what
in
that
doubt? Sir is
what is
asking
that
why you don't want
central
biopsy.
what is that central cystic mass is? Is it really a cystic, or it is something else? It can be something else.
Are you in doubt that this is a complex cyst or it's a mass? Sir is asking simply a question. In this case, will you do the biopsy?
So are you thinking it is complex cyst?
Like this is around Bosniak type 4, sir, it can be.
So if
Anyway,
it is a Bosniak type 4, then there should be a solid element inside, not outside. In this mass, there is a centrally cystic, whatever it is written, is central cystic changes. What it could be? Because if it is a complex cyst, then there is a cystic mass with inside solid element. Usually such type of presentation.
sir, to know more about the characteristic of the mass, I need CT, sir.
Exactly. There you are. क्योंकि सिर्फ सोनोग्राफी पे decision, if you have suspicious of inflammatory mass, if you have suspicion of lymphoma, then if you are suspicion of metastasis somewhere another primary, ऐसा कुछ है तो immediately ये stage पे भी बोल सकते कि yes, biopsy is needed, or if you have suspicion of malignancy or not malignancy. But treatment plan depend on only sonography cannot be done.
Yes, sir.
Okay, so more characterization. Centrally cystic mass means that may be necrosis, central tumor necrosis. Looks
yes,
like cystic element on sonography.
Yes, sir.
तो CT होना जरूरी है पहले.
Yes, sir.
So basically, in today's class, you're just learning different ways to justify. Whatever you say, you justify it. Okay?
Yes, sir.
अगर वो cystic mass consider करे तो CT करेंगे कि contrast enhanced ultrasound करेंगे.
CT is more preferred, sir. If patient is thinking, sir, in this case, CT is more preferred.
If you are suspecting it is as a complex cystic mass or cystic mass, CUS is better or CT is better?
For differentiating T like Bosniak 2F and Bosniak 3, C contrast enhanced ultrasound is better, sir. But because of that, there will be over staging, like more number of Bosniak 2F are also getting diagnosed as Bosniak 3, and then patients are undergoing surgery. So first we will do CT, sir.
Mahendra.
So, sir, it is like that whether Bosniak 2, 3, 4, 5, it is always better to do a CT scan in a one staging. If suppose that CT scan is equivocal, then you can go ahead with the
Correct.
doing the contrast in a sonography, because that can characterize the this thing to basically
Equivocal cystic masses.
differentiate between the 2 and 2F, like that, right? So
Yes, sir.
so this is you should answer, not like that ki I will do sono contrast enhanced ultrasound first and do, and I don't know the cost of contrast in enhanced sonography, but it is, I think, little bit costly compared to normal sonography. And maybe
Now you know
okay.
one of the indications of sonography post CT. That is an important thing.
Yeah, and if in expert hand with a normal sonography machine, they can tell 2 and 2F very easily. Sometimes we do in TMH. Yeah. Okay, CT scan हुआ है फिर?
तो CT scan दिखा मेरा.
मैं सोता हूँ सुबह निकल. I will leave 6 o'clock. मैं छोड़ देगी तुमको.
There is a enhancing mask.
देखो पानी पीती. तो पानी पीती.
There is a hypodense mass in lower pole of left kidney towards anterior aspect. More than 50% are exophytic, like more than 50% are exophytic. Homogeneous in nature, sir. I think homogeneous.
Vijay, do you have any other slide? Yeah, now
In
see.
this, sir, there is a heterodense lesion in left lower pole. Maybe approaching till renal sinus fat. Exophytic, more than 50% are exophytic. And artery, one vein is seen. One artery is seen. Excretion. In bladder, no growth. Ureter, no filling defect. Pelvic calcium system, no filling. And the tumor is looking like seen inside the gerota, like fat planes are maintained around the tumor.
So what is the score? Renal score?
C2, R2, E1, R2, E1, N around 2 or 3, L is 1, 2, 2 plus 3, around 8, sir, approximately.
Bridges, show the report. Just read the conclusion.
Sir, evidence of a
moderate-sized, well-defined exophytic lesion in the lower pole of the left kidney. Measures approximately 4.8 cross 4.7 cross 4.7. On dynamic contrast, mass lesion shows thick peripheral rim enhancement, no infiltration renal sinus fat or pelvic LSL systems. 2 accessory renal arteries are arising directly from the aorta, inferior to the left main renal artery. So renal nephrometry score is 7A.
Okay, fine. So Solarite, now what you want to do?
as the score is 7A, we will convince the, like, we will counsel the patient with empathy and sympathy about the prognosis, like about the disease. It is looking like renal cell, like complexes, Bosniak. It can be malignancy, like.
So chances of malignancies are very high, and patient already have got hematuria. You will like to remove this part, okay, and you like to do a nephron saving surgery. It will be possible to do nephron saving surgery. Very rarely you will end up doing nephrectomy. Correct?
Yes, yes, sir.
Right. So you would like to do nephron saving surgery, correct?
Yes, sir.
Okay, fine. So how will you do it? Which method you will like to do?
Robot assisted laparoscopic partial nephrectomy, sir. The patient, after catheterization, patient is posted in, after getting clearance for surgery, patient is catheterized and posted in, like, left flank position, port placed, and initial dissection of bowel mobilization is done with laparoscopy, and once kidney is mobilized, like once bowel is mobilized, hilum dissection can be done with robot or can also be done with laparoscopy. Then once hilum is dissected, we'll keep bulldog clamps ready, and we will score the margins of the exophytic mass. Then we'll dog the robot, apply bulldog clamp, then start cutting with scissor robotically. And
my question is, why you are not, if you are going to use the robot, why you don't want to dock it from the beginning? Why you want to do it laparoscopically?
We can dock it from the beginning also, sir. There is no harm.
No, but why not? You just justify it. No, why not?
Laparoscopic dissections we are doing day to day, sir. Like it is more.
No, but when you are going to listen, when you are going to use the robot, why you are not using it from the beginning?
We can,
don't
sir. We
say
can.
Like this in exam. Either you say laparoscopic or you say robotic.
Yes, sir.
Why you want to do it? Which is easier? Laparoscopy or robotic? Mobilization and everything?
Robotic, sir.
Then, and already you are going to use robot, then why you want to wait?
Yes, sir.
Initially, I can understand that if there are adhesions and lots of adhesions are there, that is the time you want to do adenolysis before docking, that's okay. Or either you do only laparoscopy. And if it is becoming difficult, then you will decide for the robot. You want to save the money. Don't make this mistake. Though people who are doing robotic surgeries, they will get annoyed. Nowadays, many people are doing.
Yes, sir.
See, there are some protocol your institute might be doing. But sometimes that protocol, if it is not acceptable, it's not,
But
logical.
routinely, do you do like that?
In actually initial bowel mobilization, residents will be doing it, so they.
Yeah, that is a different scenario, but usually do your bosses do like that? They don't do, no? They will go directly for robot only, no? What you're doing daily, that you should say.
Sir. Yes.
Okay, fine. The pathology report. Okay, how much time is acceptable? Shall I write?
Sir,
whether you do the warm ischemia period or you do it with the putting the ice?
We use the warm ischemia time only, sir. Like we don't prefer ice, sir. So warm ischemia time of 25 minutes are acceptable, sir. In this case, renal nephrometric score is 7A, so expecting that we can do it, sir, before 25 minutes.
Okay, is there any publication paper which says that it is not necessary that you have to finish in 25 minutes, even if you take longer. The ultimate outcome is the thing, Nephron 7 is not affected. Okay, first thing,
40
because our
minutes warm ischemia time is acceptable. So
see, we have first thing here thesis is on this only. First thing, can you just put some lights, throw lights on that?
Sir, we did a study on this, sir. We determined the warm ischemia, the role of warm ischemia time and effect of warm ischemia time on split renal function and EGFR at 3 months, sir. At our institute, patient underwent partial nephrectomy, either open, laparoscopic, or robotic, for a nephrometry score of more than equal to 7, T1A tumors. So in that, we had 15 patients who had undergone the surgery with a ischemia time less than 30 minutes, and there were 25 patients who had an ischemia time of more than 25 minutes, sir. At 3 months, sir, there was a decline in there was a mean decline of around 5 in EGFR, and there was slight decline in the renal function of the affected kidney or the operated kidney, but it was not statistically significant. It was not statistically significant. It was the result, sir. And the maximum ischemia time that was there in the study was 40 minutes, sir. So this was for T1A tumors with a score of more than equal to 7.
The purpose very much purpose behind 20 to 30 minutes is proximal tubular changes occur in 20 minutes. If it is warm ischemia, 20 minutes. Then if it is 30 minutes, there is a cellular degeneration moderate. And if it is 60 minutes, cellular degeneration complete. Okay. So if you don't want to get completely distracted your kidney, so time should be 20 to 30 minutes. That is the study well proved and published in various uropathological journals, and the very much reason behind that is 20 to 30 minutes is this one. So warm ischemia should be 20 to 30 minutes.
okay, sir.
And after seeing the histopathology report, is it a complex cyst or renal tumor with central necrosis?
It's papillary renal cell carcinoma, WHO grade 3, and tumor size of 5.6 centimeter.
My question is, it is a complex cystic mass or it is renal tumor with central necrosis?
It is a renal tumor with central necrosis.
Okay.
Okay, so that is the case.
Then
Now,
question can be asked like, sir, what are the how will you hop clamp, early unclamping, selective clamping, warm ischemia पे questions पूछ सकते हैं partial का अगर चल रहा है तो.
yes, you can. So we finish the third case just, and then whatever is your questions are there, we finish it.
Okay.
Because the third case is little Brijesh. Third case, you just show them the CT scan and the pathology report.
Yes, sir.
Because the third case is little different. But just say very quickly.
So this was a 63-year-old female had complained of mild flank pain over right side, and there was a swelling over the neck, which was thyroid mass. So patient was evaluated, and we found that she is having right renal mass. Patient underwent right partial nephrectomy. So we just wanted to discuss that after the histopatho report, it suggested this is the mass.
First, just show them the this thing, CT scan.
Yes.
Okay, Solaraj or anyone you want to comment before we go for final report?
hypodense lesion in upper and middle pole of right kidney, which is around 4 centimeter in with the necrosis maybe
Okay,
with
fine.
with
So
segmental
anyway,
artery.
yeah. This was a tumor which was removed. Hmm? So just see the margin, the renal parenchymal cut margin, including the separately sent revised margin, show presence of tumor and the lymphovascular invasion not identified.
Yes, sir. Now we may need to revise, like we have to go for radical nephrectomy, sir.
Now my question is, what is the role of frozen section? Okay, Mahendra, can you now just throw some light on frozen section as well as when positive margin comes, then how to go about?
So, sir, frozen section is a like a choice, not a mandatory thing. Just like in TMH, we are now doing frozen section for last 7 years in NSS. But whenever we are in doubt that plane was missed and anything, then definitely we send the frozen section. Coming about the margin positivity, if it is a focal, normally when we dissect the tumor, we come to know which plane is wrong and we go little bit deeper, something and remove the mass. But anyway, in doubt, at the same time, either we can send for the frozen and we can wait for the report and then we can revise the margin. Somehow, like in this case, the report came late after the patient has been maybe discharged or maybe like so. If it is a focal margin, we can observe. Maybe few margins we can observe, but gross positive, then again only two option remains to remain. Either we should go ahead inside and revise the margin or do the radical nephrectomy. So this is how it should be approached the positive margins in the NSS. But definitely at the initial stage when anybody is doing NSS, it is always better to send the frozen to get the confidence of that till they get the confidence of that level, then they can avoid sending frozen section. This is my take. There is no as such guidelines कि आपको frozen section भेजना ही भेजना है नहीं भेजना है. No guidance, individual choice.
Okay,
Yeah.
fine. But there are some institute which has got a protocol of sending the margin. And another thing which I liked about your statement is that you, after removal of the specimen and before sending for the pathology, you open up and then see whether there is any chances of positive margin, correct?
Yes, sir, that is always safe because if I am sure कि I have taken a good margin, because many times what happened कि at the base of the tumor it is like just like an enucleation. Only at the lateral border we get the margin. So only that part only it is there. But if I am in the right plane and mass is not appears to be infiltrative, then it is okay. But if mass is appears to be infiltrated the parenchyma, then definitely it is always safe to send for the frozen.
So my question is that first you suture the kidney and then you remove the mass, or first you remove the mass and then suture the kidney?
Sir, always remove the mass because kidney warm ischemia and we cannot wait for another 1 hour or half an hour for the frozen section. So it's always better remove the mass, suture the kidney, send for the frozen. And if it is positive, again clamp the kidney and open the suture and again resect the mass.
Okay.
So
Fine.
positive surgical margin, Mahendra, if it is increased, it increases the risk of recurrence. But is there any impact on cancer specific or overall survival?
No, sir.
Until
There
an
is no
average, it is grossly positive.
grossly positive data has shared. There's a no difference
That,
between the OS.
with
No,
that statement, I am agreeing with your statement about gross positive because it either need revision or radical.
yeah.
But if it is not
So
gross
sir,
positive, then
mhm.
observation is better because
Observation, sir. Sir, again,
because
it depends on the patient apprehension. If patient is okay with that, I will come to follow up or recurrence hoega, then I will go for radical nephrectomy.
I
Then
agree.
what the patient is saying, oh, how did it happen? And I am not able to sleep. It is inside. The better to go ahead with the remove the. It all depend on the patient response actually.
Correct. But as far as scientific cancer specific or overall survival, there is
No,
no
no,
any
sir.
impact.
No difference, sir. No difference.
So,
Okay, fine. So that is the reason we wanted to discuss this case. That once you get a positive margin, then how you are going to. So now in this case, how you are going to follow up, Solaira? Now you don't want to. Patient says, I don't want to go for the second surgery. You also accept that now you don't want to do the radical nephrectomy. Then how will you go about?
Sir, every 3 months we will do CT, sir, for next 1 year, and then 6 monthly CT scan till 3 years, then yearly CT scan, sir.
Yes, uh, Mahendra, in this case, what is your comment?
So, sir, as in this case, margin positive, I would like to have a more closer follow-up, maybe 3 monthly CT scan for 1 year, and maybe 4 monthly in the next 2 year. If then okay, then I can do a 6 monthly, then annually, because at the most recurrence will occur within 2 years. So it will be a little bit
Okay.
more close follow-up because it comes in you can say high risk category. If I would say like put in the category because margins are positive.
So Solai, now in after 1 year, if that CT scan is showing that there is some growth, some mass seen in the kidney, now what you will do?
Sir, we are able to do nephron sparing first. We have to try for nephron sparing, sir. Then, if not possible, then radical.
No, it's already you removed the part of the kidney, na? And this time you want to take chance or you want to do the radical nephrectomy?
Better to go for radical, sir.
Okay. Yes. What is your opinion, Mahendra? How you go about in
I would just like to a scenario that I twist करता हूँ मैं. If suppose that it is a single kidney.
Yeah.
Then definitely revision of the margin of whatever the tumor recurrence is there, it would be safer. And if it is not, then definitely radical nephrectomy will be the better. But it is a small, then RFA can be done by for that small lesion, and radical nephrectomy can be reserved for the later.
Okay. Fine. So, Solaraj, when you will tell patient says, doctor, you please tell me when I'm absolutely disease free. What will be your answer?
After 5 years, sir. No, sir. Even after that also, every yearly, if it is high risk patient, we have to do yearly follow-up, sir. So there is no point.
Means I didn't get you. What you're saying?
After till 5 years, there will be till 3 years there will be 6 monthly follow-up, sir. After 6 months, after 3 years there will be yearly follow-up. So lifelong patient has to come for follow-up, sir.
Mahendra, in this case, how many years of follow-up is required?
So, sir, again, this is something which is not in the guidelines. So,
in this case, I think after 5 year, one annual follow-up is required, because we last year we have seen a case of stage 1 disease. After 12 year, he got metastasis of in the
Oh,
lung of RCC. So to be very honest, even stat says that it is not like that, but for one patient, it is the family that is important. So I think
hmm.
no harm in giving an exceptional case, deviating from the guidelines and do the annual follow-up for lifelong, it is also justified.
Okay, fine. Yeah, we are not losing anything by just
No, sir.
doing one CT scan or something like that.
Yeah.
What is the role of sonography after 5 years? Or is there any role
Can be
after
done,
3 years?
Sir, can be done with the at the center. It means high volume center and experienced people. Good sonography is also equal, but definitely it is not be able to pick up the 1 centimeter mass, but more
Hmm.
than that, it can pick up. Only thing is that problem is that in the post-operative area, it should be reported by the very experienced sonologist.
Correct. Yeah, I've seen, but because we also went to sonography after partial nephrectomy, we get weird report if the sonologist is not good. You know,
Yeah.
that's true.
Sir,
Fine.
in what we do in high risk features, जैसे ये grade 4 disease and having some
Hmm.
other pathology. So we do only CT scan for 1 year, maybe
Okay.
three monthly, then 5, then 6 monthly, and then after we switch over to 6 monthly sonography and 6 monthly CT scan.
Okay. So high risk patients, you always prefer CT scan over ultrasonography.
Yeah, right, sir. Yeah.
For chest,
Okay.
we do CT, sir, till 5 years for high risk, or just chest X-ray is enough for like
For
how to go
RCC, normal RCC, all guidelines says 5 years. But again,
chest.
they say after 5 year, individualize the follow-up.
Sir, with chest CT or chest ultra, chest X-ray, sir, it is not clear for me.
Always do chest CT in metastasis.
Okay, sir.
Yeah.
Okay. Gite sir, you want to add anything?
नहीं सर, डिस्कशन तो काफी हुआ है. बाकी और एखादा मेटास्टैटिक आरसीसी आ ही जाएगा तो उसमें फिर और ऐड कर देंगे.
हाँ. So now next time I have requested our head of the department, radiology, that is Dr. Raju Mehta. He is one of the first to start a CT scan in city of Mumbai and a very renowned radiologist. So he is one of the best in CT scan as well as in MRI. So I requested him. So next time we are having metastatic type of renal disease. So in that first half an hour or 40 minutes, he will talk about the CT scan, will show different how to go about and what are the important features you should look into the CT scan and MRI and what is the role of both. And then we will go ahead with our case. Is that okay for everyone?
Yeah, nice. Good idea, sir.
Yeah. Okay then. Huh? Thanks.
Okay, sir.
Thanks, Raj.
Okay.
Thank you, sir. Thank you,
Okay.
sir.
Good night,
Good night,
students.
sir.
Good night, Gaurang sir, Gite sir,
Yes.
Mahendra
Good night.
bhai.
Yes. Good night.
Good
Good
night.
night, Hiren bhai. Good night. Good night,
Happy
everybody.
journey for tomorrow, Hiren.
Thank you, sir. Thank you, sir.
And do well in your
Yes, sir.
presentation.
Yes, sir.
Okay?
गीते साहब मिलते हैं.
यस आ रहे क्या इधर?
Yes, sir. Yes, sir.
ठीक है सर, आ रहे क्या आप उधर? हाँ, इधर आ
नहीं,
रहे
मैं
हैं
नहीं
आप?
आता हूँ. तन्वी आती है. तन्वी is coming ना. Tanvi is there.
ठीक है, मैं हूँ, फिर मिलते हैं.
Yes, sir.
Yes. Okay.
Bye, sir.
Bye.
Good night, sir.
गुड
Good
नाइट.
night.